So in this second section regarding the tumors of the stomach, we'll be studying about the management. How can we manage a patient with the stomach cancer? So we'll be studying about how does a patient present a patient with gastric cancer, what are the clinical features regarding gastric cancer, and then how can we investigate a patient with gastric cancer, what are the different investigations and diagnoses that we can diagnose gastric cancer, and then the different types of staging techniques regarding gastric cancer on the basis of diagnosis and treatment, and the prognosis and treatment modalities that we can offer a patient with gastric cancer. So most of the patients with gastric cancer are usually asymptomatic. Around 80% are asymptomatic, and if the symptoms they do occur, they're usually very slight and not pronounced, such as weight loss being around 60% of patients present with weight loss, and secondly abdominal pain. Around 50% of patients with gastric cancer present with abdominal pain. Third being different types of clinical features such as nausea, vomiting, anorexia, and dysphagia, which is the painful swallowing, and lastly melena. Melena is the presence of blood within the stool. So if we talk specifically about gastric cancer, paraneoplastic syndrome can usually occur, but it's sometimes very rare. And if we talk about the sites of spread regarding gastric cancer, and this can be one of the clinical features and one of the diagnostic points regarding the diagnosis of gastric cancer. First being the periumbilical lymph nodes, which is around the umbilicus, and it's also known as the Sister Joseph's nodules. The second being the left supraclavicular sentinel nodes, which is also called as Virchow's node. So there is as the left supraclavicular nodes are being enlarged, and there's a prominence within the left side of the neck, such as in this picture. We can see this development or this growth is known as Virchow's node, which is a very characteristic feature of gastric cancer. The third being the pouch of Douglas, which is the rectal shelf of Plummer. This is also a characteristic feature, and it is one of the sites of spread of gastric cancer and metastasis. And lastly, it involves the ovaries, which is then known as the Krukenberg's tumor. So these are the different sites of spread regarding gastric cancer when metastasis has occurred. Other than that, gastric cancer has also been associated with different types of diseases, such as the nephrotic syndrome and DIC, which is the disseminated intravascular coagulopathy, and some sort of neuropathies. So if we talk about diagnosis, there are different types of investigations that can be performed on a patient with gastric cancer, but esophagogastroduodenoscopy, such as endoscopy, is one of the treatment of choice regarding the diagnosis of gastric cancer. The second being the CT gastrography, which is also being studied these days, and lastly the serum markers are also slightly useful in the investigations regarding gastric cancer. So if we talk about endoscopy specifically, like I've told you, that it is the treatment of choice, it is the investigation of choice regarding the gastric cancer. So if we see a non-healing ulcer in the through the endoscope, at least 6 to 8 biopsy specimens from the edge of the ulcer and from the base of the ulcer is very necessary. Second, the endoscopy in patients is very necessary in patients who are older than 55 years old, and specifically if they present with a new onset of dyspepsia or heartburn. Other than that, there are different types of endoscopy methods, such as the chromoendoscopy and the magnification endoscopy, chromo being the use of a specific dye or stain. And lastly, narrowband imaging are also used specifically alone or in combination with other types of endoscopy, such as chromoendoscopy or these magnification endoscopy. So in this picture, what actually happens in an endoscopy, what happens is that a tube-like structure is passed through the oral cavity of the patient, and it consists of a small micro camera within the tube, and it is passed through the esophagus into the stomach, and the picture is being seen through a screen, and the tube consists of a light and a camera, and thus, it is helpful in having a clear picture of the mucus of the mucosal cavity of the esophagus and the stomach. So, if we talk about the other types of investigation, one being the CT gastrography, a lot of studies are going on these days to know the significance of CT gastrography. Other than that, it is usually for the diagnosis of early gastric cancer as compared to late gastric cancer, and the sensitivity is around 73 to 76%. And if we talk about serum markers are not that significant in the investigation of gastric cancer, but are usually used. One being the low serum progesterone levels and the low ratio of progesterone 1 to progesterone 2, and high gastrin levels being the hypergastrinemia. And second, there are different markers such as the TGF beta 1 and the CA72 for tumor M2 pyruvate kinase, and hepatocyte growth factors are potential markers that are being studied these days to see if it's helpful in the investigation of a gastric cancer. So if we specifically talk about staging the gastric cancer, the staging is usually preferred with the classification known as the T and M classification, and it is usually used by the International Union of Against Cancer, which is known as the UICC, and the American Joint Cancer Academy, known as the AJCC. So these are two organizations that have preferred the use of TNM classification. So T, if we talk about T is the depth of the tumor, how far has the gastric cancer or the tumor have involved. And other than that, the N specifically indicates the number of lymph nodes that are involved regarding the cancer, and M being the metastasis, if metastasis has occurred or not. So in this table, we've seen that TIS is known as the tumor in situ, so it has no lymph nodes involved, and it has no metastasis that occurs. And then T1 can be classified as 1A if there is no nodal involvement, 1B if there's one node involved, 2A being the two nodes involved, and 2B being three nodes involved. Similarly to T2 is when there's the no node involved is 1B, and if there's a single node involved, it's known as 2A, and two nodes or three nodes, then it goes on like 2B and 3A. Similarly, if we talk about the last stage regarding gastric cancer, T4 and T4A and B, it's subdivided into two, one being 2B and 3B, and then lastly, if we talk about the metastasis, if it has occurred, then it's completely known as 4 and 4. So in this diagram, we've seen the tumor involvements. So if we talk specifically about the early gastric cancer, so we can see that tumor in situ is just the tumor that invades the mucosa and which is very superficial. If we talk about T1, the involvement is around the mucosa and the superficial and the deep mucosa. T1 can also be the tumor that has reached the submucosa, T2 being the advancement until the muscularis propria, T3 being the serosa, and T4 is when adjacent organs have been also involved. So if we talk about another type of endoscopy, which is known as the endoscopic ultrasound. So this endoscopic ultrasound has been useful in in staging the different layers of the gastric cancer wall. One being the superficial gastric mucosa is presented as an echogenic first layer. So the second layer is the deeper mucosa, which is represented as a hypoechogenic second layer. Third being the submucosa, which presents as an echogenic third layer. Fourth, the muscularis hyperpropria as an hypogenic layer. And lastly, the serosa, which is represented as a hypogenic echogenic layer. So if we talk about the different treatment modalities that we can offer a patient, first being the surgery, which is usually for the early diagnosed gastric cancer. Secondly, the EMR and ESD, which is the endoscopic mucosal resection and the endoscopic dissection. Third being the use of chemotherapy, chemoradiation, and lastly the intraperitoneal chemotherapy is a very latest technique to treat gastric cancer. So if we talk about surgery in specific, the resection remains primary curative treatments, just such as that if the patient has been diagnosed with T1 or T2AB staging of gastric cancer, they are it is very useful with the help of surgery. The tumor can be completely resected. And then the surgery is being divided into two types of gastrectomies. First being the total gastrectomy, which is performed usually on the proximal type of gastric tumors, and then it is also performed for the diffuse gastric cancers. And secondly being the partial gastrectomy, that half of the stomach is being resected, and it is usually reserved for the distal tumors. So as we can see in this picture, a patient comes up with a more distal type of gastric cancer. So there is a partial gastrectomy that occurs. So half of the stomach is being resected. As you can see, some parts of the duodenum, the antrum, and half of the body of the stomach is being resected. And then after surgery, what happens is that the proximal part of the stomach is then being connected with the small intestine, the rest of the duodenum. So this surgery is the partial gastrectomy. Secondly, if we talk about endoscopic mucosal resection and ESD, so this type of treatment or this type of surgical procedure is usually for the early gastric cancers. So there's a criteria regarding the endoscopic mucosal resection. First is that the cancer is in the mucosa and lymph nodes are not involved. So only these patients are being treated with endoscopic mucosal resection. Second is the maximum size of the gastric tumor should be less than 2 centimeters, and the lesion is slightly elevated. And if we talk about no evidence of multi-epigastric cancers or simultaneous abdominal cancer, so patients should present with these types of cancers, such as the cancer mucosa is involved and the lymph nodes are not involved. Maximum size of the tumor should be less than 2 centimeters and it should be slightly elevated. And there should be no evidence of any multi-epigastric cancers or any abdominal simultaneous cancers. And lastly, the cancer should be of intestinal type. This EMR is not being used on patients with diffuse type of cancer. So as you can see in this picture, an endoscopic tube is being used and a snare is used, which causes suction, and it causes the elevated part of the gastric cancer to be cut off with the help of with a snare, which is called as polypectomy snare. So if we talk about the ESD is a submucosal injection is performed first as the marking is being done, and then this injection is being injected to the deep layer of the tumor. And then with the help of an endoscopic electrosurgical knife, the tumor is being resected. So after the injection, the tumor is slightly elevated, and then a snare type knife is being used, which cuts the mucosa. This type of surgery, it allows assessment of the depth of the invasion, which does not help in the endoscopic mucosal resection, and it is also used for the assessment of lymph nodes metastasis. So we can also figure out if the patient has metastasis within the lymph nodes. So what happens is that there's a marking done, and then injection is injected in the deep layer of the tumor, and then the mucosa is being cut and dissection occurs, and then finally the complete resection of the tumor occurs. So if we talk about chemotherapy, chemotherapy these days is used on a very high scale. Sometimes patients are usually resistant to conventional type of chemotherapy, and 15 to 20% patients have a reduction with the risk of gastric mortality. And neoadjuvant chemotherapy is usually used these days, which has appeared to be very beneficial. And lastly, there's a chemoradiation type of therapy, which is combined with surgical resection, which appears to be effective. And then there's a neoadjuvant chemoradiation, which has also shown good results. So most of the patients, they present around 70 to 80% of patients, they usually present at a stage where surgery is not applicable, and patients can only be treated with the help of chemotherapy and chemoradiation, as the tumor has involved the adjacent organs and metastasis has occurred. So in this section, we've studied about the management, we've studied about the clinical features, the diagnosis, and different types of treatment modalities that can be offered. That's all from this section. Thank you for watching sqadia.com.